Okay, now we're going to hook the pig lungs up to a ventilator, a mechanical ventilator, and we're going to demonstrate a couple things, basic respiration with the ventilator, and then what positive end expiratory pressure does, or we call it PEEP. And then we're going to turn the PEEP up so you can see the difference it makes for different types of patients that we would use it for.
Alright, so you can see the ventilation much more effective when we're on the ventilator. I have this set up with a pressure setting, so our pressure is at 30 centimeters of water pressure, and then we currently have a PEEP set at 3, which would be fine depending on what diagnosis that your patient has. But for those patients who need a lot of PEEP, somebody who has refractory hypoxemia or somebody who has ARDS, we have to use a lot of PEEP, and so we end up increasing that PEEP in order to increase the oxygenation, which works really well for alveolar recruitment and rebound or refractory hypoxemia. But we work so hard, and you can see us increase the PEEP, how much more inflated the lungs become and end up staying because we keep that baseline at a higher level. And so we'll just keep increasing the PEEP. I've got it up to 8 now.
And I'm going to add in here for the nursing students, we're not as savvy with ventilator lingo and what things like PEEP are, but if you'll know what PEEP basically is the pressure that the ventilator is going to leave in the lungs, so we don't have alveolar collapse and lose all of that headway that we've made with mechanical ventilation. So basically, in a nutshell, that's what PEEP helps us to do.
If you zoom up right here, you can see some of this area that's been collapsed. This whole video is, you can see that alveolar recruitment. All those little air sacs are starting to pop open with every breath. And that's the point, because if they're not filling with air, then they're not carrying that oxygen to the blood to be carried to the rest of the body. So
you can notice that there's a whole lot more air basically left in these lungs after each inspiration as there was when we first began, because we've increased from a PEEP of 3 to a PEEP of 8.
So this is exactly what we want. We want all those air sacs to be working together, but then we've gotten the patient where we want them to be, and we've gotten the oxygenation up, but now we need to break that ventilator circuit to either give some medication or to change the ventilator circuit. And then what happens is we get this huge de-recruitment of alveoli in just a couple breaths, just long enough to unhook that circuit. And it takes a few breaths just to get back up to where we were, let alone any kind of therapeutic PEEP.